Rhabdomyolysis. Rhabdomyolysis is a clinical syndrome characterized by breakdown of skeletal muscle fibers with subsequent release of muscle cell contents into the bloodstream. Rhabdomyolysis can develop due to a wide variety of precipitating events and conditions. Most of these initiating factors lead to muscle cell injury through two primary mechanisms: depletion of ATP and/or direct damage to the plasma membrane. ATP depletion impairs the function of ion pumps that maintain appropriate electrolyte levels within the myocyte. Plasma membrane damage also disrupts electrolyte homeostasis by allowing uncontrolled passage of ions between the intracellular and extracellular spaces. Both mechanisms result in a rise in intracellular calcium levels, causing mitochondrial dysfunction and activation of phospholipases and proteases that further disrupt cellular integrity. The end result is myocyte death with release of intracellular contents into the bloodstream, including various proteins and electrolytes. Leakage of potassium and phosphate from injured muscle cells frequently results in hyperkalemia and hyperphosphatemia, while deposition of calcium salts into the necrotic tissue often leads to hypocalcemia. The necrotic myocytes also create a highly osmotic local environment that results in uptake of free water into the damaged muscle tissue, causing hypovolemia. Myoglobin, a heme-containing protein that serves as an oxygen reservoir, is also released by degenerating muscle fibers. Myoglobin is toxic to the kidney and can cause proximal tubular injury as well as tubular obstruction due to formation of heme pigment casts. Myoglobin-induced acute kidney injury is frequently exacerbated by volume depletion and the resulting renal ischemia. Creatine kinase is another muscle protein released during rhabdomyolysis. This enzyme is involved in the storage and transfer of high-energy phosphates and is clinically useful as a marker of muscle injury. The causes of rhabdomyolysis are frequently categorized according to the mechanism of myocyte injury. Traumatic causes include crush injuries, extensive burns, surgical procedures, and prolonged immobilization. These processes can directly damage muscle fibers or lead to compression of blood vessels with resulting ischemic injury. Rhabdomyolysis can also occur due to non-traumatic causes, which are further classified as non-exertional and exertional. Exertional rhabdomyolysis occurs when energy supply to the muscle is insufficient to meet metabolic demands, resulting in ATP depletion. This can happen with strenuous or prolonged physical activity or exertion in very hot and humid weather. Other conditions that predispose to exertional rhabdomyolysis include pathologic hyperkinetic states, neuroleptic malignant syndrome, malignant hyperthermia, and inherited muscle disorders. Non-traumatic, non-exertional rhabdomyolysis can occur due to metabolic disturbances or following exposure to certain toxins or medications. Numerous prescribed and recreational drugs can induce rhabdomyolysis via various mechanisms. Some of the more commonly associated drugs include lipid-lowering medications such as statins and fibrates, ethanol, and cocaine. Rhabdomyolysis can have a variable presentation. The condition can be mild, with some patients experiencing only an asymptomatic rise in creatine kinase levels, or it can be severe, with significant muscle symptoms and development of complications such as acute kidney injury. The classic triad of findings in rhabdomyolysis includes muscle pain, weakness, and reddish-brown dark-colored urine due to myoglobinuria. However, the full triad is seen in less than 10% of patients. Other symptoms include muscle swelling due to local fluid accumulation and peripheral edema from concomitant acute kidney injury. Since the characteristic triad of rhabdomyolysis is not always present, a high index of suspicion should be maintained in patients with known risk factors for the condition. The most reliable method to confirm the diagnosis is laboratory evaluation. An elevated serum creatine kinase level is a hallmark of rhabdomyolysis and the most sensitive laboratory finding. Levels begin to rise within 2 to 12 hours following the onset of muscle injury and are usually greater than 5 times the upper limit of normal. Urinalysis can also be helpful for making the diagnosis. The dipstick test for blood detects the heme component in myoglobin and hemoglobin, not actual RBCs, so a positive dipstick test in the absence of RBCs on microscopic examination can provide supportive evidence of myoglobinuria. If untreated, rhabdomyolysis can lead to severe complications. As mentioned, kidney injury due to acute tubular necrosis is a common consequence of myoglobinuria. Clinical manifestations include an increase in serum creatinine and characteristic pigmented granular casts on urine microscopy. Compartment syndrome can also occur in the involved muscle areas due to inflammation and third spacing of fluids. This leads to increased pressure within the fascial compartment, limiting perfusion of the enclosed tissues, which can be limb-threatening if not treated with emergent fasciotomy. Cardiac dysrhythmias, and in extreme cases, sudden cardiac death, can occur due to the electrolyte imbalances associated with rhabdomyolysis, most notably hyperkalemia. The main goal in the management of rhabdomyolysis is to recognize and treat the resulting fluid and electrolyte abnormalities. Intravenous fluids are administered to maintain kidney perfusion and limit myoglobin toxicity in order to prevent acute kidney injury. Electrolyte imbalances should also be corrected to prevent complications such as cardiac arrhythmias. Appropriate management of precipitating factors, such as identifying and discontinuing offending medications, is also important to prevent persistent or recurrent rhabdomyolysis. To sum up, here are the key points to remember. Rhabdomyolysis is characterized by skeletal muscle breakdown with release of intracellular contents into the bloodstream. Most cases are triggered by a precipitating factor that causes depletion of ATP and/or cell membrane damage. A subsequent rise in intracellular calcium levels leads to activation of phospholipases and proteases that result in myocyte death. The most common causes of rhabdomyolysis include trauma, strenuous physical activity, overexertion in hot climates, and drugs or toxins. Patients classically present with the triad of myalgias, muscle weakness, and dark urine. Laboratory findings include elevated serum creatine kinase, a hallmark of the disorder. Many patients also characteristically have a positive dipstick test for blood, with no RBCs seen on urine microscopy due to the presence of myoglobin in the urine. Acute kidney injury is the most frequent complication and develops due to heme pigment-mediated tubular injury. Urine microscopy typically reveals granular, muddy brown casts. Electrolyte disturbances are also frequently seen and can cause complications, including cardiac dysrhythmias. Compartment syndrome may occur due to swelling of the involved muscles. The main goal in the management of rhabdomyolysis is to recognize and treat the resulting fluid and electrolyte abnormalities in order to prevent acute kidney injury and other complications. The prognosis is generally favorable with appropriate treatment.